Assalamualaikum, good afternoon everyone. I am Nomina K. Mala, the second reporter of Topic12. In this video, I will be discussing the remaining disorders of sleep-wake disorders. For my topic outline, these are the sequence of my discussion. So without further ado, let us start discussing the rapid eye movement or REM sleep behavior disorder. In REM sleep, you lose muscle tone and become paralyzed, a state known as atonia, of course except for the breathing process. REM sleep behavior disorder or RBD in short is a parasomnia characterized by dream enactment behaviors that emerge during a loss of REM sleep atonia. Nawawala yung paralysis state ng isang tao pag natutulog, yung tinatawag nating atonia. Another feature of RBD is vocalizations such as shouting and grunting. It is a prodromal syndrome of alpha-synuclein neurodegeneration. Prodromal syndrome is a technical term used by mental health professionals to describe a specific group of symptoms that may precede the onset of a mental illness. So RBD precedes the onset of neurodegenerative diseases. Meaning, kapag na-diagnose ang isang tao ng RBD, malaki ang possibility na magkaroon din siya ng neurodegenerative disease. And we will tackle it more as we go on in this discussion. The main focus of treatment is to reduce behavioral events and prevent sleep-related injury. So the following are the diagnostic criteria of REM sleep behavior disorder. For criterion A, repeated episodes of arousal during sleep associated with vocalization and or complex motor behaviors. Dito, nangyayari yung dream enactment where an individual acts out his or her dream. These behaviors often reflect motor responses to the content of action-filled or violent dreams of being attacked or trying to escape from a threatening situation. Yung vocalization may be bothersome kasi malakas siya, emotion-filled, and profane. While yung sa motor behaviors naman may be both bothersome and dangerous kasi nga violent ang content ng dreams nila, so their behaviors is more likely to be violent. Pwedeng naninipa, nanununtok, nananakal, nanghe-headlock, etc. For criterion B, these behaviors arise during REM sleep and therefore usually occur more than 90 minutes after sleep onset or more frequent during the latter portions of the sleep period and uncommonly occur during daytime naps. Next, criterion C, upon awakening from these episodes, the individual is completely awake, alert, and not confused or disoriented kasi usually, nare-recall nila kung ano ang context or content ng panaginip nila. Next, for criterion D, either of the following. Number 1, REM sleep without atonia on polysomnographic recording. And number 2, a history suggestive of REM sleep behavior disorder and an established synucleinopathy diagnosis. Ito na yung neurodegenerative disease na sinasabi gaya ng Parkinson's disease and multiple system atrophy. So in case you're not familiar of Parkinson's disease, it is a brain disorder that causes unintended or uncontrollable movements such as shaking, stiffness, and difficulty with balance and coordination. For criterion E, the behaviors cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. This is determined depending on number of factors including the frequency of events, gaano kadalas nangyayari, the potential for violence or injurious behaviors, embarrassment, and distress in other household members. Next, the disturbance is not attributable to the physiological events of substance kaya ng drug abuse or other medication or another medical condition. And lastly, criterion G, coexisting mental and medical disorders do not explain the episodes. Sa pagdetermine ng severity kung gaano kalala ang REM sleep behavior disorder, it is best made based on the nature or the consequence of the behavior rather than simply on frequency. Although the behaviors are typically prominent and violent, lesser behaviors may also occur. In epidemiology, RBD have a prevalence of 0.5 to 1.25% in the general population, 2% in older adults. Among the people diagnosed with RBD, 33 to 50% of them developed Parkinson's disease. 80 to 95% are diagnosed with multiple system atrophy, and 80% of them have dementia with Lewy bodies. It is widespread among patients with Parkinson's disease, multiple system atrophy, and dementia with Lewy bodies, since isolated RBD is a prodromal syndrome of alpha-synuclein neuropathology. Yung prevalence niya sa mga patients na may psychiatric disorder is mas malaki, which is possibly related sa mga gamot that was prescribed for their psychiatric disorder. The onset of REM sleep behavior disorder may be gradual or rapid, and the course is usually progressive. Majority of the patients diagnosed with RBD are older men, those aged over 50 years. It happens rarely to children. It was also found out that patients with confirmed or possible RBD are more likely to smoke, have fewer years of education, report heavy alcohol use, have a concurrent mood disorder, use antidepressants, and report a history of traumatic brain injury, welding work, and pesticide exposure. Moving on, what are the comorbid disorders of RBD? REM sleep behavior disorder is present concurrently in approximately 30% of patients with narcolepsy. When it occurs in narcolepsy, the demographics reflect the younger age range of narcolepsy with equal frequency in men and women. More than 70% of individuals with initially idiopathic REM sleep behavior disorder will eventually develop a neurodegenerative disease, and ang kadalasang comorbid ng RBD ay isa sa synucleinopathies, and those are Parkinson's disease, multiple system atrophy, or mild or major neurocognitive disorder with Lewy bodies. Kadalasang nauuna ng ilang taon o dekada ang RBD before magkaroon ng symptoms ng mga neurodegenerative disease. So you might question now, what causes REM sleep behavior disorder? RBD is the clinical manifestation of a variety of central nervous system pathologies, all of which result in a failure to inhibit spinal motor neurons. Number 1, alpha-synuclein pathology is the most common cause of RBD. In the absence of provoking medication or comorbid neurodegenerative disorder, it is the presumed cause of all cases of isolated or idiopathic RBD. RBD confirmed by video polysomnography is among the strongest early predictors of Parkinson's disease. However, symptoms are typically either dismissed as clinically insignificant or misattributed to some other etiology. Even prior to the onset of a neurodegenerative syndrome, patients with RBD have evidence of diffuse and progressive neuropathology. Number 2 is non-synuclein neurologic disorders. Among patients with mild cognitive impairment, when a clinician is concerned about the possibility of impending Alzheimer's disease, inquiring about dream enactment is useful. Dito, kailangan ng straightforward na questions like, have you ever been told that you act out your dreams? So, these questions helps distinguish patients who will ultimately go on to develop dementia with Lewy bodies. So, kung yung answer is affirmative, dementia with Lewy bodies yan, or DLB. Kapag naman negative, like wala pang nagsabi sa kanya na nagkakaroon siya ng dream enactment behavior, that would constitute to Alzheimer's disease. Post-traumatic stress disorder increases the odds of developing RBD in war veterans. This association has been noted even in the absence of comorbid traumatic brain injury. Number 3, narcolepsy and state boundary control. Approximately 50% of patients with narcolepsy have RBD. Yung failure ng orexin na i-stabilize ang REM sleep ang nagkukos ng dream enactment behavior na related sa RBD, with a resulting intrusion of wakeful muscle tone. Number 4, pontine lesions. Natitrigger ang dream enactment behavior ng structural lesions sa brainstem due to vascular, demyelinating, neoplastic, and traumatic etiologies. Lastly, medications. Approximately half of all RBD patients developed dream enactment after initiating a serotonergic antidepressant medication, typically SSRI, SNRI or serotonin modulating agent. Serotonergic RBD appears to be the most prevalent form of RBD among the young people or those younger than 40 years old. Now, moving on to treatments. I just want to reiterate na ang main focus ng treatment of RBD is to reduce behavioral events and prevent sleep-related injuries. So, establishing a safe sleeping environment is the primary goal of treatment. This can be achieved through modification of the sleep environment and, if necessary, pharmacotherapy. So, the following are the recommended or suggested treatments of RBD. Number 1, safe sleeping environment. The frequency of dream enactment behaviors is not predictive of injury, so all patients with RBD and their bed partners should be counseled on modifying the sleeping environment to prevent injury. Kung mild lang ang symptoms, it is recommended that firearms should not be accessible, and sharp or easily breakable furniture and objects like lamps should be removed from the immediate sleeping area. So kapag nagtuloy ang vigorous behavior ng isang patient, ina-advise na matulog ng mag-isa yung patient. A bed alarm that delivers a customized calming message at the onset of dream enactment can also prevent a patient from exiting the bed and avert sleep-related injury. Number 2, reversible factors. Medications known to exacerbate RBD, including the serotoninergic antidepressants, should be discontinued or avoided if possible in patients with RBD. Ito ang listahan ng mga medications na nagpapalala ng RBD. So since these medications exacerbates RBD, must prefer ang bupropion as an antidepressant as it has not been reported to induce RBD unless otherwise contraindicated in patients with RBD and depression who require pharmacotherapy. And the third one are pharmacotherapy. All patients with frequent, disruptive, or injurious behaviors should be treated with pharmacotherapy to reduce behaviors and lower risk of injury. So in pharmacotherapy, we have melatonin, cholinergic agents, dopamine agonists, and others. Melatonin is our preferred first-line therapy in patients with frequent, disruptive, or injurious behaviors. It tends to be better tolerated than the alternative first-line therapy, clonazepam, especially in older adults with neurodegenerative disorders. Next are clonazepam. Low-dose clonazepam has long been recognized as a treatment for RBD. Like melatonin, the therapeutic mechanisms of clonazepam and RBD are not fully understood, although it is thought that clonazepam may reduce the frequency of unpleasant dreams, thus decreasing violent dream enactment behavior. Kahit sufficient na ang low doses ng clonazepam, may mga side effects ito that can limit its utility. Next is cholinergic agents. In patients who fail melatonin and clonazepam therapy, cholinergic agents may be useful. In one small placebo-controlled crossover trial, acetylcholinesterase inhibitor rivastigmine reduced the number of dream enactment behavior episodes in patients with Parkinson's disease and RBD. Next, dopamine agonists. While dopaminergic medications are the standard therapy for daytime motor symptoms of Parkinson's disease, they are rarely effective for RBD alone. And others. Other agents with some reported success include imipramine, carbamazepine, sodium oxybate, triazolam, zopiclone, quetiapine, and clozapine. Restless legs syndrome or RLS. Also called Willis-Ekbom disease, it is a sensory-motor neurological disorder characterized by a desire to move the legs or arms because of an uncomfortable sensation. From the term itself, may kakarampot na tayong idea kung ano nga ba ang RLS. Ito naman is kadalasan siyang nangyayari kapag gabi when you're sitting or lying down, and yung uncomfortable or unpleasant feeling is na-alleviate siya kapag gumagalaw yung isang tao. For the diagnostic criteria, A. An urge to move the legs, usually accompanied by or in response to uncomfortable and unpleasant sensations in the legs, usually associated with uncomfortable sensations typically described as creeping, crawling, tingling, burning, or itching. Yung pakiramdam nila may gumagapang sa legs nila or nangangate or parang kinikiliti ang legs nila or arms nila. This is characterized by all of the following. Number 1, the urge to move the legs begins or worsens during periods of rest or inactivity. Number 2, the urge to move the legs is partially or totally relieved by movement. And number 3, the urge to move the legs is worse in the evening or at night than during the day or occurs only in the evening or at night. Mas malala yung urge nila to move their legs pag gabi kumpara sa umaga kasi usually 'di ba ang gabi is time ng pahinga. Again, mas malala yung symptoms pag ang isang tao is at rest or walang ginagawa. So ang nangyayari is mas madalas yung paggalaw ng legs ng individual para mawala yung uncomfortable sensations na nararamdaman nila. Next, the symptoms in criterion A occur at least 3 times per week and have persisted for at least 3 months. For criterion C, the symptoms in criterion A are accompanied by significant distress or impairment in social, occupational, educational, academic, behavioral, or other important areas of functioning. The diagnosis of RLS is primarily on patient self-report and history. Criterion D, the symptoms in criterion A are not attributable to another mental disorder or medical condition and are not better explained by a behavioral condition. And lastly, the symptoms are not attributable to the physiological effects of a drug, of abuse, or medication. Next, epidemiology. Prevalence rates of RLS vary widely when broad criteria are utilized. Kapag ang in-employ na criteria is yung mas defined, ang prevalence is nagre-range from 2% to 7.2%. When frequency of symptoms is at least 3 times per week with moderate or severe distress, prevalence rate is 1.6% and the rate is 4.5% naman when frequency of symptoms is a minimum of 1 time per week. 1.5 to 2 times naman na mas malaki ang possibility ng babae na magkaroon ng RLS kumpara sa mga lalaki. RLS increases with age and the prevalence may be lower in Asian population. The onset of RLS typically occurs in the second or third decade of life, and approximately 40% of individuals na na-diagnose ng RLS during adulthood ay nagsasabi na nagsimula nilang maramdaman ang mga symptoms bago sila mag-20 and 20% naman ang nagsasabi na na-experience nila ang symptoms before 10 years old. Prevalence rates of RLS increase steadily with age until about age 60 years kung saan yung mga symptom ay nananatiling stable or nagdi-decrease siya ng konti in older age groups. Familial cases of RLS has a younger age at onset and a slower progressive course compared with non-familial cases. And ang clinical course ng RLS ay nag-iiba by age at onset. Kapag yung onset is nangyari before mag-45 years old ang patient, mabagal ang progress ng symptoms. While in late onset RLS, rapid progression is typical and aggravating factors are common. For comorbidity, the main medical condition comorbid with RLS is cardiovascular disease. RLS is associated with higher rates of depression, generalized anxiety disorder, panic disorder, and post-traumatic stress disorder. Maaari ring associated or comorbid ng RLS ang iba pang medical conditions gaya ng hypertension, migraine, Parkinson's disease, multiple sclerosis, peripheral neuropathy, diabetes mellitus, fibromyalgia, osteoporosis, obesity, thyroid disease, and cancer, as well as other sleep disorders including narcolepsy and obstructive sleep apnea. RLS is common in those with iron deficiency, pregnancy, and chronic renal failure and can dramatically improve once these conditions resolve. Usually, the cause of RLS is unknown. Ito yung tinatawag na primary RLS. However, it has a genetic component and can be found in families where the onset of symptoms is before age 40. Up to 92% of patients with RLS have a first-degree relative with the disorder, which implies the hereditary etiology of RLS. Also, specific gene variants have been associated with RLS. Evidence indicates that low levels of iron in the brain and/or iron deficiency also may be responsible for RLS. There are also considerable evidence which suggests that RLS is related to neuropathy or nerve damage and a dysfunction in one of the sections of the brain that control movement, called basal ganglia, that use the brain chemical dopamine. Dopamine is needed to produce smooth, purposeful muscle activity and movement. Disruptions of these pathways, the basal ganglia, frequently results in involuntary movements. Individuals with Parkinson's disease have increased chance of developing RLS. There are also certain medications that may aggravate RLS symptoms, such as anti-nausea drugs, antipsychotic drugs, antidepressants that increase serotonin, and some cold and allergy medications that contain older antihistamines. Pregnancy was also found to cause RLS, especially in the last trimester. In most cases, nawawala rin yung symptoms 4 weeks after delivery. So how is restless legs syndrome treated? RLS can be treated with care directed toward relieving symptoms. Moving the affected limbs may provide temporary relief. Sometimes, RLS symptoms can be controlled by finding and treating an associated medical condition such as peripheral neuropathy, diabetes, or iron deficiency anemia. The following are treatment options for RLS. Number 1, lifestyle changes. Certain lifestyle changes and activities may provide some relief in persons with mild to moderate symptoms of RLS. These steps include avoiding or decreasing the use of alcohol and tobacco, changing or maintaining a regular sleep pattern, a program of moderate exercise, and massaging the legs, or using a heating pad or ice pack. There are new medical devices that have been cleared by the U.S. Food and Drug Administration, including a foot wrap that puts pressure underneath the foot, and another that is a pad that delivers vibration to the back of the legs. Aerobic and leg stretching exercises of moderate intensity also may provide some relief from mild symptoms. Number 2, iron supplementation. For individuals with low normal blood tests called ferritin and transferrin saturation, a trial of iron supplements is recommended as the first treatment. Iron supplements are available over the counter. A common side effect is upset stomach, which may improve with the use of a different type of iron supplement. In some people, iron supplementation does not improve a person's iron levels. Others may require iron given through an IV line in order to boost the iron levels and relieve symptoms. Healthcare providers will likely prescribe medications when RLS symptoms are frequent or severe, like Number 1, anti-seizure drugs. Anti-seizure drugs are becoming the first-line prescription drugs for those with RLS. This drug appears to be as effective as dopaminergic treatment, and at least to date, there have been no reports of problems with a progressive worsening of symptoms due to medication called augmentation. Number 2, dopaminergic agents. These drugs, which increase dopamine effect, are largely used to treat Parkinson's disease. They have been shown to reduce symptoms of RLS when they are taken at nighttime. These drugs are generally well tolerated but can cause nausea, dizziness, or other short-term side effects. Next, opioids. Drugs such as methadone, codeine, hydrocodone, or oxycodone are sometimes prescribed to treat individuals with more severe symptoms of RLS who did not respond well to other medications. Side effects include constipation, dizziness, nausea, exacerbation of sleep apnea, and the risk of addiction. However, very low doses are often effective in controlling symptoms of RLS. And lastly, benzodiazepines. These drugs can help individuals obtain a more restful sleep. However, Even if taken only at bedtime, they can sometimes cause daytime sleepiness, reduce energy, and affect concentration. Benzodiazepines such as clonazepam and lorazepam are generally prescribed to treat anxiety, muscle spasms, and insomnia. Because these drugs also may induce or aggravate sleep apnea in some cases, they should not be used in people with this condition. These are last-line drugs due to their side effects. Another disorder that we will be discussing is the substance or medication-induced sleep disorder. It is a disorder characterized by a prominent sleep disturbance that is sufficiently severe to warrant independent clinical attention and is judged to be primarily associated with the pharmacological effects of a substance or medications. The following are the diagnostic criteria of substance medication-induced sleep disorder. Letter A prominent and severe disturbance in sleep. Criterion B, there is evidence from the history, physical examination, or laboratory findings of both. Number 1, the symptoms in criterion A develop during or soon after substance intoxication or withdrawal or after exposure to or withdrawal from a medication. And number 2, the involved substance or medication is capable of producing the symptoms in criterion A. Criterion C, the disturbance is not better explained by a sleep disorder that is not substance or medication-induced. Such evidence of an independent sleep disorder could include the following. The symptoms precede the onset of the substance or medication use, meaning na unang ma-experience ang symptoms kesa sa simula ng paggamit or exposure ng substance or medication. The symptoms persist for a substantial period of time, like, say for instance, about 1 month after the cessation of acute withdrawal or severe intoxication, or there is other evidence suggesting the existence of an independent non-substance or medication-induced sleep disorder. Halimbawa ay ang history ng recurrent non-substance or medication-related episodes. Next, the disturbance does not occur exclusively during the course of a delirium. Hindi lang sa tuwing nagde-delirium nangyayari yung disturbance. And lastly, the disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. It is important to note that this diagnosis should be made instead of a diagnosis of substance intoxication or substance withdrawal only when the symptoms in criterion A predominate in the clinical picture and when they are sufficiently severe to warrant clinical attention. So these are the specifier of substance medication-induced sleep disorder. So when diagnosing substance medication-induced sleep disorder, if there are difficulty falling asleep or maintaining sleep, frequent nocturnal awakenings, or non-restorative sleep, specify insomnia type. When predominant complaint of excessive sleepiness or fatigue during waking hours or less commonly a long sleep period is present, specify daytime sleepiness time. These two are the most common, whereas parasomnia type is seen less often. Parasomnia type is specified when abnormal behavior events during sleep are present, and specify mixed type if there are substance or medication-induced sleep problem characterized by multiple types of sleep symptoms but no symptom clearly predominates. So these four are used in subtype designation, whereas these three specifiers naman is used in recording the specification of onset. Specify also with onset during intoxication if criteria are met for intoxication with the substance and the symptoms develop during intoxication. With onset during withdrawal if criteria are met for withdrawal from the substance and the symptoms develop during or shortly after withdrawal. And lastly, with onset after medication use, if symptoms developed at initiation of medication, with a change in use of medication, or during withdrawal of medication. So we have a table here on the coding of specific substance medication-induced sleep disorders. Take note that the ICD-10-CM code depends on whether or not there is a comorbid substance use disorder present for the same class of substance. Itong ICD-9-CM naman is sa DSM-5 lang siya meron at hindi na siya included sa DSM-5-TR. For recording procedure of ICD-9-CM, the name of the disorder is followed by the specification of onset followed by the subtype designation. Halimbawa, 292.85 alcohol sleep-induced disorder with onset during intoxication, insomnia type. So, ganito ang format kapag iisang substance lang ang associated sa development ng sleep disturbance at ganito naman if higit sa isa. Ito naman ang sa ICD-10-CM na meron both sa DSM-5 and DSM-5-TR. So, same lang din sa ICD-9-CM, ang kaibahan ng isa pag-record. So, to record the name of the disorder, the comorbid substance use disorder, if any, is listed first. Following the word with, followed by the name of the substance or medication-induced sleep disorder, followed by the specification of onset, followed by the subtype designation. So, ang nadagdag lang is yung name ng comorbid disorder. Halimbawa, F10.282 severe alcohol use disorder with alcohol-induced sleep disorder with onset during intoxication, insomnia type. At kapag dalawa or higit pa ang associated disorder or associated substance, of course, ililista mo rin kung ano pa yung ibang disorder, just separated by a semicolon gaya rin ng sa ICD-9-CM. Next, epidemiology. Recreational substances are prevalent in adolescence and early adulthood and help-seeking behavior for the sleep disturbance in these age groups is limited. Thus, corroborative report may be elicited from a parent, caregiver, or teacher. Older individuals take more medications and are at increased risk for developing substance medications-induced sleep disorder. Individuals with major neurocognitive disorder are also at risk, hence corroborative report from caregiver or caregivers is particularly important. In terms of comorbidity, insomnia disorder, hypersomnolence disorder, central sleep apnea, sleep-related hypoventilation, and circadian rhythm sleep-wake disorders, shifter type, are the common disorders comorbid of substance medication-induced sleep disorder. Abuse, chronic use, and exposure of the following psychoactive substances can cause substance-induced sleep disorder. Medications are also known to cause substance medications-induced sleep disorders, including adrenergic agonists and antagonists, dopamine agonists or antagonist, cholinergic agonists or antagonists, serotonergic agonist or antagonist, antihistamines, and corticosteroids. Isang key factor na kinoconsider when diagnosing a patient with a substance or medication-induced sleep disorder is yung onset ng symptoms as stated in Criterion C. Kapag yung onset ng symptoms ay before pa gumamit ng isang substance or substances or before ma-expose or mag-take nitong mga medications na ito, hindi substance or medication-induced sleep disorder ang diagnosis. However, kapag yung symptoms ay nagsimula after ng onset ng substance or medication use and it meets the other criteria, then that's the case na ang diagnosis ay substance or medication-induced sleep disorder. As for treatments, I haven't found information in the references na binigay ni ma'am and even sa internet. Though one recommended way para ma-manage ang symptoms ng substance or medication-induced sleep disorder is to gradually stop using the substances and medications that causes it hanggang sa yung patient is completely na itinigil na yung paggamit or pag-take ng mga substances or medications. So moving on, this category, the other specified insomnia disorder, and the next one, the unspecified insomnia disorder, applies to presentations in which symptoms characteristic of insomnia disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria for insomnia disorder or any of the disorders in the sleep-wake disorders diagnostic class. So ito ang other specified insomnia disorder, and yung sunod, yung unspecified, is ginagamit siya kapag yung yung symptoms ng insomnia disorder is hindi fully na-meet. The other specified insomnia disorder category is used in situations in which the clinician chooses to communicate the specific reason that the presentation does not meet the criteria for insomnia disorder or any specific sleep-wake disorder. This is done by recording other specified insomnia disorder followed by the specific reason. Say for instance, short-term insomnia disorder. So ilan sa mga examples ng presentations kung saan pwede ma-specify using the other specified designation include the following. Number 1, short-term insomnia disorder if the duration is less than 3 months. And number 2, restricted to non-restorative sleep if the predominant complaint is non-restorative sleep unaccompanied by other sleep symptoms such as difficulty falling asleep or remaining asleep. While ang unspecified insomnia disorder category naman is ginagamit in situations kung saan ayaw i-specify ng clinician ang reason kung bakit hindi na-meet ang criteria for insomnia disorder or a specific sleep-wake disorder. And it includes presentations in which there is insufficient information to make a more specific diagnosis. Ang recommended treatments for the other specified and unspecified insomnia disorder is yung treatments din for insomnia disorder. So again, other specified kapag hindi na-meet yung full criteria at gusto i-specify ng clinician yung reason. And unspecified naman kapag yung criteria for insomnia disorders is hindi na-meet completely and kapag hindi enough yung information para makagawa ng specific na diagnosis. So next, itong dalawang category naman, ang other specified hypersomnolence disorder at unspecified hypersomnolence disorder applies to presentations kung saan hindi na-meet ang full criteria ng hypersomnolence disorder or any of the disorders in the sleep-wake disorders diagnostic class. The other specified hypersomnolence disorder category is used in situations in which the clinician chooses to communicate the specific reason that the presentation does not meet the criteria for hypersomnolence disorder or any specific sleep-wake disorder. This is done by recording other specified hypersomnolence disorder followed by the specific reason. For example, brief duration hypersomnolence as in the Klein-Levin syndrome. And unspecified hypersomnolence disorder naman is ginagamit in situations kung saan ayaw i-specify ng clinician ang reason kung bakit hindi na-meet ang criteria ng hypersomnolence disorder or any specific sleep-wake disorder, and kapag hindi enough yung information na meron para makagawa ng specific na diagnosis. Ang recommended treatments for the other specified and unspecified hypersomnolence disorder is yung treatments din for hypersomnolence disorder na na-discuss ni Christine Morales. So moving on, itong dalawang category naman, ang other specified sleep-wake disorder at unspecified sleep-wake disorder applies to presentations kung saan hindi na-meet ang full criteria ng sleep-wake disorder or ng iba pang disorders under sa sleep-wake disorders diagnostic class. The other specified sleep-wake disorder category is used in situations in which the clinician chooses to communicate the specific reason that the presentation does not meet the criteria for sleep-wake disorder. This is done by recording other specified sleep-wake disorder followed by the specific reason. For example, repeated arousals during rapid eye movement sleep without polysomnography or history of Parkinson's disease or other synoclinopathy. Lastly, unspecified sleep-wake disorder naman is ginagamit in situations kung saan ayaw i-specify ng clinician ang reason kung bakit hindi na-meet ang criteria for sleep-wake disorder or a specific sleep-wake disorder. And itong unspecified sleep-wake disorder naman is ginagamit rin siya kapag hindi sufficient yung information na na-gather mo to make a more specific diagnosis. So that will be all for my discussion. Here are my references. So kung may questions or clarifications kayo, just ask me or chat me and I'll try to answer it as much as I can. Thank you!